Dr. Jagan sir, surgical gastroenterologist from SNHRC, Dr. Badan Prasanna sir, critical care, SNHRC, Dr. Deepa ma'am, physician, AIMS Madurai. On to the stage. Dr. Vamshi sir, medical gastroenterology from VGM Coimbatore. Let's welcome our next speaker, Dr. Asisha Janeela, hepatologist from CMC, who will share their insights on chronic liver disease, conservative strategies in untransplantable liver.
Next, we call upon Dr. Kayalviri ma'am for chairperson.
For inviting me for this meeting. So the topic given to me is conservative strategies in untransplantable chronic liver disease. Now this is a very broad topic. I know it's lunchtime. I will just be giving the key concepts of management of advanced liver disease. Now this is the outline of my presentation. What is the burden of advanced chronic liver disease? What are the goals of care? How do we optimize management of portal hypertension? We will also look at managing malnutrition and psychological support in these patients. Now this is just highlighting the burden of liver disease globally. Now there are 112 million people living with compensated cirrhosis, with 10% per year decompensating. By decompensation we mean patients who go on to develop ascites, GI bleed, patients who develop encephalopathy or jaundice. Now the median survival in patients with compensated cirrhosis is 12 years, whereas the median survival in decompensated cirrhosis is 2 years. This is again just to highlight, there are 2 million deaths annually and India contributes to around 1/5 of these deaths. So it is there is a high burden of this disease and it is associated with a high mortality. Now we know that as portal hypertension increases, complications of portal hypertension increase. That is, patients develop varices, they develop ascites, they develop variceal bleed, leading on to refractory ascites. Again, just highlighting that this is a spectrum of disease going on from compensated cirrhosis, decompensation and late decompensation. We can see the portal pressures, normal being less than 5, going on more than 10, we call it clinical significant portal hypertension. So with increase in portal hypertension, we can see that decompensation worsens. Now today I'm just going to be concentrating on this group of patients, that is patients with advanced chronic liver disease. Now we all know the best or the curative option for decompensated cirrhosis would be liver transplantation. However, in our country we know that there are a lot of barriers to liver transplantation. So there are financial constraints, there is lack of donors, the patient may be too sick by the time he reaches counseling for transplant is done. A lot of socio-economic and psychological factors as well. Now, keeping these barriers in mind, how do we manage? I'm pretty sure that most of us who are here would be managing a lot of patients who have advanced chronic liver disease, in whom liver transplantation is not an option. Now, what do we do for them? Now, these are patients, like I said, with a median lifespan of around 2 years. How can we best medically manage them? How can we improve their quality of life? Now, keeping this in mind, what would be the goals of care in advanced liver disease? The first would be, this is in a patient in whom transplant is not considered. So, improving the quality of life of that patient, optimizing management of portal hypertension, improving nutrition, providing psychological support, and how do we decrease hospital admissions in these patients. Now, the first thing that I would be talking would be about portal hypertension. Now, this is a topic by itself and I can speak on and on about it, but I will just pick 2 symptoms. That is 2 complications. One is ascites, second is encephalopathy. Mainly because these are 2 distressing complications with which most of our patients with end-stage liver disease keep coming again and again to the hospital. So first being hepatic encephalopathy. So confusion generally is a very distressing symptom to the patient and to the caregivers. There is loss of independence, loss of employment, increased hospitalization. Now, first thing is we should be able to pick up these symptoms and manage them. Find out what are the triggers. One of the most common trigger for hepatic encephalopathy is constipation. So the first line of management is providing laxatives like lactulose, and we target 2 to 3 soft stools per day. Now, role of rifaximin has been well studied in recurrent HE. We know that rifaximin may decrease the episodes of HE, may improve the quality of life. However, rifaximin is an expensive drug and this limits its use. However, when possible, rifaximin can be given. Moving on to the second complication, that is ascites. Almost 60% patients with cirrhosis develop ascites. This is one of the most common indication for hospital visits. Many of our patients come with need for recurrent taps, recurrent ascitic taps. So how do we manage this ascites? So this is a stepwise management approach. I would just tell it in few practical points. The first thing is looking at diet, salt restriction, which is around 2 grams per day. Second mainstay is diuresis. The two common diuretics that we all know about is Lasix and aldactone. Now the starting doses for Lasix would be around 40, for aldactone would be around 50, and the highest doses that we can aim would be 160 or 400. But we all know in clinical practice we never reach those doses of diuretics. Because the problem with diuretics is patients can develop many diuretic induced complications like acute renal injury, they can develop hyponatremias, hyperkalemias. So we need to optimize based on their serum electrolytes and creatinine, what is the optimal dose of diuretics a patient can tolerate. Now a patient with grade 3 ascites, that is patient having gross or tense ascites, the management would be a large volume paracentesis. What do I mean when I say large volume paracentesis? Would be removing around 3 to 5 liters of ascitic fluid at one go. Now when we are removing that large volume of ascites, we should also give them albumin. Why? That is to prevent paracentesis induced post-circulatory dysfunction. So whenever we are doing a large volume tap, we should give albumin to the patients, and the dose recommended is 8 gram per liter. So if we are removing 5 liters of ascites, actual dose as per guidelines is around 40 grams, which is 2 vials of albumin. However, in clinical practice, we don't end up giving that much of albumin. Now, certain drugs we should be careful with when a patient has ascites. Avoid using NSAIDs. NSAIDs can worsen acute renal injury. Avoid ACE, ARBs. Again, they can worsen renal injury in patients with ascites. Also be careful with aminoglycosides. Now, as cirrhosis progresses, many of the patients go on to develop refractory ascites. What is refractory ascites? When they are not able to mobilize, when the ascites is not mobilized, even with good diuretics and with diet control, it can be intractable ascites or it can be resistant refractory ascites. Resistant meaning that even with the maximum doses of diuretic, patient is still having ascites. When we say intractable refractory ascites, patient is not able to tolerate the dose of diuretics. What do we do? Now, things we can do. One, large volume paracentesis. We see many of our patients coming weekly to our OPDs to get these large volume paracentesis along with albumin. Now diuretics, we need to be careful. By the time they reach this stage, they may not tolerate diuretics. Third, now this is a very controversial topic, role of beta blockers in refractory ascites. We should be cautious and if possible try to avoid beta blockers in patients with last stage liver cirrhosis. Now once we've talked about these broad things, the other things that we can do is tips. That is, we all know about the indications, contraindications, and one of the more common complications of tips being hepatic encephalopathy. Now this is an interesting thing that I came across that we don't do here, but putting drains for ascitic fluid. Now this has been studied in the West, whereby you tunnel a drain and you put it into the peritoneal cavity. You can leave it for almost a month. Patient doesn't have to come to the hospital. Every 2 to 3 days, patient can remove around 1 to 2 liters. Now studies have shown that this improves quality of life. However, there is a little bit more complications like renal injury. But however, when we're looking at advanced liver disease, we are looking at quality of life. So putting these drains may be a good way forward. Maybe in some more time we may have more data on that. Now another question that keeps coming, should I give albumin to these patients in OPD? Should I give weekly albumins? So there's a lot of studies that have been done. Some say for, some say against. But overall it's good to know that albumin given once a week or once in 2 weeks has shown some improvement in the albumin levels, improvement in decreasing the decompensation and decreasing infections. However, we need to know that albumin is an expensive drug. It costs around 5,000, and at the doses that have been described, it is very, very expensive for our patients. So knowing these limitations, albumin does have a role in patients with cirrhosis. Now, having said, I'm not going to the other complications of portal hypertension due to want of time. The other domain that we need to be careful about is malnutrition. 50% of cirrhotics will be malnourished. Two terms which we keep hearing about would be sarcopenia, frailty in terms of decompensated cirrhosis. Sarcopenia is loss of muscle mass. This leads to more complications, more infections, lower survival. Hence, when we are looking at these patients in OPD, we should always be mindful whether these patients are adequately taking nutritionally good intake. So the optimal daily energy intake is around 35 kilocalories per kg. Optimal protein is around 1.2 to 1.5 grams. Now, few things that in OPDs we tell them are egg whites, which are a good source of proteins. Again, we tell patients about including a late evening snack. This decreases the time of starvation. For very sick patients, we may need to consider enteral nutrition. Now, one of the last aspects that I would look at is psychological support. 1 in 6 patients with cirrhosis has moderate to severe depression. Half of them have severe anxiety. So when we are holistically looking at a patient, it is important to actively look for this symptom and address it. How can we address? One, referring to a psychologist for counseling. Second would be pharmacotherapeutic drugs. However, be careful, few of these pharmacotherapeutic drugs can have a sedative role, so we should be careful when we are giving them drugs for depression or anxiety. Now, overall, it is holistic symptom control. Many of them will say they have generalized pain. One simple drug that we can give is paracetamol. Though we all think paracetamol can affect the liver in reduced doses of 2 to 3 grams, it is a perfectly safe drug. Avoid NSAIDs. Fatigue, counsel your patients for optimizing sleep and encouraging light activity. As said, for dyspnea and abdominal discomfort, paracentesis is the way to go. This is just a picture where we have said by the time it's end-stage liver disease, if transplant is the best option, it is the curative option. However, if this is not possible, switch on to the other two modes, that is a patient-centered symptom control. Here the goal is not cure. Here the goal is how do we prolong the life, how do we improve the quality of life. And by the time it's end stage, how do we give the patient comfort. So with this I end my talk. Advanced liver disease requires a multidisciplinary team. You need a dietitian, a psychologist. Managing the complications of portal hypertension is the goal. Preserve nutrition and muscle mass, support mental health and quality of life. Thank you.
Wonderful lecture. I think it was completely wholesome, how to manage a patient who cannot go for new transplant. And I just want to share my experience on regular albumin infusion in these patients, whether who don't have a facility to go for transplant or do not have a donor. So we have had a small study in Ramchandra where we used to give twice a month albumin, not weekly, twice a month albumin. There were about 50 patients had come, and then we could probably see that the need for repeated paracentesis had come down, need for hospitalization for infections had come down, and the rate of encephalopathy had come down. And as you say, it is an expensive drug. Then we started to motivate these patients to have albumin at their native place. Most of them are coming from outside Chennai. So about one third of them still used to come and report to us as a review, continuing to take that, and then we found that it did really prolong life with probably improved quality. I don't know about CNC whether you have the same experience or not, but these are all patients who probably had no scope for transplant.
We do give, sir. If patient is an affordable patient, we do advise them that we give them the option actually and discuss with them. If it is a feasible option for the patient, we do give them. Yeah.
Yes, like the sir told, like we are also had same experience, sir. Like once in 2 weeks we used to give. Like this, what the sir told exactly, we also seen like reduced rate of paracentesis and reduced rate of hospitalization, and the sense of well-being is good, and the need for diuretic is reduced, and the cramps all get reduced, and sequentially the serum albumin also tend to rise actually. It's surprising actually. Yes, like I think we actually adopted this from liver transplant surgeons actually. Those with very high bilirubin, they give like weekly once albumin. Thus, they reduce the renal complications and they make them fit for a transplant. With this adaptation, like we evolved actually, and we also following, and we also found it is useful.
Yeah, I have few queries. What is the role of this 5% albumin that has been recently used? And second question, like sedatives in terminally ill cirrhosis patients, we cannot give regular dose of benzodiazepine. They are not hepatic encephalopathy patient, but still they require some form of sedative. Whether melatonin is enough or something else we have to give. And then this long-term devices, what we keep. Is there any Indian methods, because it is not like pleural effusion and just put there will be no infection. In this, the risk of infection is very high. I just want this queries.
The second question that you asked, sir, that is role of sedatives in end-stage liver disease. Now, I would look at what are we looking at. So, if we are looking at a patient who is terminally ill in our wards, then there my goal for care would be comfort of the patient. If the patient is agitated, I wouldn't mind giving the benzodiazepine, knowing that it is not a curative option but comfort for the patient. But having said that, the other group of cirrhotics who keep coming in and out, we should be careful about benzodiazepines, because then we won't be able to see whether is it a hepatic encephalopathy versus a sedative effect. So few drugs for like depression and anxiety and other things that the studies have shown are SSRIs, that is a few drugs like escitalopram and mirtazapine. All these drugs may have a role at a lower dose. So whenever we are starting these drugs, not at the full dose of how we would give a normal person, but at maybe a 3/2, a half dose, and then built based on the patient's tolerability. Second, you asked me about long-term drains. As of now, I don't have experience. We don't do long-term drains here, but there are a lot of studies from UK. Actually, there's a randomized trial which is presently going on, which I looked up, called Reduce 2, where they're looking at long-term drains versus doing recurrent LVP. So it may come for the group of patients who are terminally ill. It may be a useful thing in the future, maybe.
Plurex device that what you are asking. Now they are promoting Plurex like for malignant pleural effusion. Like they are also suggesting same thing for ascites patient. One thing is like it is very costly actually. Like the vacuum bottle itself costs around 68,000. Like it can't be done for all the patients. Yeah, like regular paracentesis is enough, I think.
So there is midodrine is an alpha-1 agonist. Its role has been looked at ascites. Studies have shown that it may have benefit. However, guidelines still don't state it as a first line or a second line option. But in clinical practice, patients with refractory ascites who can't tolerate diuretics, we do start them on midodrine, making sure that they don't have an underlying cardiac issue.
Regarding midodrine actually like those like you told like diuretic intractable ascites, those patients and those patients with borderline blood pressure where we can actually use midodrine actually can be useful in refractory ascites actually. It works in the alpha receptors in the intrahepatic state. It reduces the intrahepatic resistance actually. By this way, it reduces the accumulation of ascites. especially those with refractory ascites who are more prone for type 2 HRS. Those patients we can use midodrain, and like we have been using midodrain, especially those patients who are more prone for renal insufficiency with very high bilirubin and all. We found it useful.
But make sure that you have adequate systolic pressure before you start using these drugs, because it might precipitate an acute kidney injury. They should be having at least a stable blood pressure.
One more drug for discussion is tolvaptan. Usage of tolvaptan, is it hyponatremia really a concern? We should use tolvaptan or not?
So tolvaptan mainly for hyponatremia. Now there are, if you ask me, we do see a lot of hyponatremia. Most of them are diuretic induced, so it responds once you stop the once you start the diuretic, most of it responds just with albumin and high salt diet. That's what in clinical practice we do. Having said that, tolvaptan has shown to increase hyponatremia, shown to increase the sodium levels in studies with good benefit. However, we are quite cautious about its use in clinical practice, so we don't routinely use it.
Tolvaptan in high doses is hepatotoxic. It should be used only 15 milligram per day with those in liver disease patients. And we usually use when the patient is symptomatic hyponatremia. Those with altered sensorium, then not routinely. Not long term, also short term. It has an important word.
That was an excellent lecture. Like Sir and Mohan said, we also use albumin regularly, maybe 10 days or once in 2 weeks to maintain the albumin level more than 3 gram per liter. So that improves a lot of outcomes for the patients. Like I said, repeated needed for hospitalization, tapping, cramps, improving the quality of life overall. And like you said, managing insomnia in patients with liver disease is difficult. And in child C, we try to avoid all kinds of sedatives. Probably antihistamines may have a role in patients with liver disease. And muscle cramps is a common problem these patients present with. For them, there is not much proven therapy that helps them. Sometimes exercises, muscle relaxation techniques, and carnitine supplementation can help. And the other thing, in addition to nutrition, I would also like to highlight the importance of exercise, strength training to maintain the muscle mass, because we all know that sarcopenia, it affects a lot of parameters in liver disease management, from the symptoms of liver disease as well as the outcomes of transplant as well.
Thank you for this captivating session, ma'am.